Welcome to our Florida Interest Network webinar on what is the difference between PrEP and PEP. And so today we have a wonderful keynote speaker by the name of Avani, and I am going to turn it over to her so that she can introduce herself. Thank you, Avani, for joining us this evening.
Thank you, Irma, for inviting me. I'm really honored to speak before you all today. So my name is Avani Vijay Lakshmi Ramanathan. I work for the Florida Department of Health here in Miami-Dade County. I work for the HIV STD Department in Prevention and Education, and I'm the Transgender Services Coordinator for the county. And that's really important. I really like to take the pride that I'm the first Transgender Services Coordinator here in this county, because we're a really important community when it comes to HIV prevention. Trans women of color are 15 times more likely to have HIV than any other population in this nation. But despite the need, and despite the high need for PrEP, which I'll go into what it means and everything like that, despite the high need for this medication, trans people are least likely to be on PrEP across the nation, especially in the South where it's most needed. And when we look into why that is, it's because 64% of health promotion programs around this world dedicated to HIV and STDs don't even include the transgender community in their thought processes at all when they're coming up with these programs, right? And as public health professionals, I was taught, you always have to go and get the target population involved in all facets of the planning, like from the flyers that you make, from the outreach materials, from the messaging, from the people that are involved. You need to have the community involved to have a successful intervention. So we as public health professionals, I would say I've really dropped the ball in reaching out to the trans community when it comes to that. So that's why, as Transgender Services Coordinator, I really want to turn that around and really change the dialogue when it comes to trans people having HIV and trans people using PrEP. So I wanted to let you all know that, we're going to be starting a new initiative here in this county. It's going to be called the Transgender Tenacity Power Community Coalition Group. So it's going to be chaired by me, but we're also going to have a community co-chair, someone that's a transgender leader who will be elected by members of their community. And together we're going to improve the PrEP outreach, make sure that testing for HIV is more accessible and available, especially for the huge population in the trans community that has resorted to sex work because of the discrimination and prejudice that they face in employment. They really need later hours to be able to get tested and to be able to learn about PrEP. So we're really trying to ensure that in hotspots here in Miami-Dade County, especially in Miami Beach and Little Havana, that we're having late night testing hours. The DOH offers free HIV STD testing. If you get tested through us, the treatment is also free. And when it comes to PrEP, if you do it through us as well, we have a PrEP link form. We have PrEP navigators that we've hired on our staff, and we plan to expand that program. If you're a single earner making less than $40,000 a year, you can get PrEP for free through the Gilead Scholarship Program. But a lot of people aren't aware of these resources. And that's why, I really like to do webinars like this and go out and present like I did at last semester at Albizu University in person, so that I can reach out to every corner of this county and let them know about the services that are available. So I don't know if you guys, are following the president and his federal initiative, but there is a new 10-year initiative called Ending the HIV Epidemic. So this is a 10-year grant that we are now getting to hire more staff, increase resources for testing and PrEP, to reduce HIV infections by over 90% in the last 10 years. Okay, so that's just kind of the background of where I come from. So now we'll go into PEP, PrEP, and NPEP, all right? So PrEP stands for pre-exposure prophylaxis, okay? So PrEP is what you take before you come into contact with HIV. This is a preventative medication. This was approved by the Food and Drug Administration in 2012, okay? And basically what this medication does is you take it once a day. You have to, be HIV negative. You have to have a normal kidney function. You can't have hepatitis B. Sorry, you guys able to hear me?
Yes.
Okay, so you can't have hepatitis B, and you can't be taking any other drugs that contradict. And you're also required to follow up with the doctor every 3 months just to make sure that your blood work is normal. So this is a blue pill. There's two different types now. There used to be just Truvada, but recently Gilead also came up with Descovy, which they say has less of the side effects of Truvada, but it's just been introduced to the market, so we'll see how that goes. So what PrEP does is it protects your immune system. So the way that HIV impacts our body is we have these things called as T cells, right? So the T cells is core to our immune system. This is what protects us against the most basic infections: flu, cold, cough, fever, whatever you have it, right? So I'm HIV negative. So let's say right now I'm touching this wall on my house, right? There's probably some bacteria that I'm in contact with right now. But because of the high T cell count that I have, being that I am HIV negative, my immune system is protecting me against getting an infection right now. But as HIV develops in your body, it starts to break apart and rapidly multiply up to 1 million copies a day to take over this immune system. So by doing that, it also opens you up to what we call as opportunistic infections. So that means something as basic as me touching this could lead to a bacterial infection if I were to be HIV positive. So the beauty of PrEP is when you take it once a day, you start building protection against that. So let's say I've now been taking PrEP for some time. It basically forms a shield around my T cells so that if I were to say have sex without a condom, if I were to have sex with an injected drug user, or if I prick myself with a needle, it would then form a firewall around my immune system to make sure that HIV is unable to replicate. And when HIV is unable to replicate, it dies off. So when it comes to PrEP, it takes about 7 days of taking this medication to make sure that you have the maximum protection when it comes to any kind of rectal exposure, like I'm talking about like anal sex. And when it comes to vaginal exposure or blood exposure, you have to take it for about 21 days straight. And if you ever go off and stop taking it for a while, that protection also goes down. So you do have to take it once a day to keep up that protection. And if you ever stop taking it, you have to, go back, get retested, make sure that you are HIV negative to be able to take this prescription again. So unlike PrEP, is called as post-exposure prophylaxis. So this means after coming into contact with HIV. So that could mean something like, let's say you were at a party on a Friday night and you forgot to wear the condom, you were having sex with somebody that was HIV positive, and that you've come in contact with. You have 72 hours to take this medication to make sure that HIV is unable to replicate, prevent you from being HIV positive. Caveat with the 72-hour window is the earlier that you take within that 72-hour window, the more protection that you're going to. So if you take it on the first hour, then you're better off taking it on the 72nd hour. But the difference between PrEP and PEP is that PEP doesn't have to be taken once a day for the foreseeable future, right? So PEP only needs to be taken for 28 days straight in order for it to work. And PEP, unlike PrEP, does not have as much of a process in terms of getting the medication, because PEP is considered an emergency medication. So you can get it at the ER, any clinic, any hospital, 24 hours a day. Jackson, they're all really working hard to make sure that NPEP is available for people, who need it, right? So in terms of the demographics of the people that use PrEP and PEP, there's a significant difference as well. So PrEP, like I said, it's mostly for people who are in risky behavior, having condomless sex, injected drug users. Was originally invented for people working in the medical field. So let's say, I'm a doctor, I, injected somebody with a needle who was HIV positive, and, pricked myself with that needle. It was invented for people like that, to be able to take that medication within 72 hours, people that often have to come into contact with blood in a daily basis in a clinical or hospital setting. And also another demographic that tends to use PEP over PrEP, survivors of domestic violence and sexual assault. So we're seeing, especially in women of color, one of the main contributing factors for HIV infection is the experience of unwanted sexual contact of any kind. So there's a lot of intersections, as you can see, with HIV and STD. It's not just about sex. There's a lot of different issues, politics, social issues involved, right? So sexual assault survivors are one of the highest and most likely to use PEP and are most in need of it. So this would also, be a useful thing for people to learn that are social workers, working in domestic violence. I know people at Albizu University, intern and, are involved in those issues. So that's another important point that I wanted to add about PEP. So back to PrEP. So, you do have to take it once a day to have the maximum protection. But I also want to let you guys know that it doesn't mean that you have to take it forever. So one of the reasons why you might not want to take it is if you're no longer sexually active, then PrEP is not going to work for you. And you wouldn't need it, especially. It would be, a waste of resources for yourself. And also, let's say that, there's minor side effects for PrEP. Like when you start taking PrEP, just like any other medication, there's certain side effects, right? So in the beginning, you might feel a little bit of a loss of appetite, some lightheadedness, headaches. And we as professionals do suggest that people have a full glass of water, have a meal, take it right before they go to sleep. So that way they can offset some of these side effects. But everybody's body is different and adjusts to that medication differently. So for some people, those minor side effects that I'm talking about that should only last a week, it might last longer. There might be some unusual reactions that your body has based on your genetic predispositions. And if it's happening to you for a really long time, that's another red alert. You want to, go to your doctor, you want to ask them and, tell them what's going on, and they might be able to suggest an alternative for you. And the third valid reason for why you might want to stop taking PrEP is if you're somebody that's not good at taking a medication every day and being able to do it consistently. Because if you don't take PrEP consistently, if you're only doing it every other day, 2 times a week, once a week, then it's the effect of that protection is not going to be there for you at all. So at that point, if you've noticed that you aren't able to keep up with the medicine regimen, then perhaps something like using condoms, dental dams, something like that to protect yourself would be better off, right? And I also want to add another caveat when it comes to PrEP. Just because you take PrEP does not mean you can no longer use a condom and that you're forever protected against any kind of sexual disease. So one, PrEP does not protect against any other STDs. So syphilis, gonorrhea, chlamydia, herpes, HPV, you would not get that protection by taking PrEP. So PrEP plus condoms is what makes you uninfectable and untransmittable for HIV, right? So another caveat is that it's not birth control. You can still take PrEP, and if you, have condomless sex, you can still, get impregnated, have an unwanted pregnancy. So there is that as well. So that's just a little bit of an overview. I'm going to go into depth more about HIV and STD and the care continuum plan and everything like that we have. But I want to take this time from you all if you have any questions about what I've talked so far. Any doubts, anything that I've said that you guys don't understand?
So far, everything is great. And just to share with you, Vani, I have taught the required HIV course for mental health counselors now for the last, I don't know, 18 years or something. And last year when I was updating my information was the first time that Broward County had any information on transgender. So even acknowledging that as a group is brand new. I was wondering some of the things you were talking about, the 10-year grant and these other efforts that are happening in Miami. This video is going to be available to statewide, to all of Florida. So are any of these grants or initiatives happening in other parts of our state?
Yes. So actually, I want to add that this grant is a federal initiative. So the federal government has given money to what they call as high-risk states. They've given it to certain states that have high risk, and they've also given it to certain cities that have high risks. So certain cities in Florida, Tallahassee, Jacksonville, Miami, Orlando, Tampa, all of these cities have now gotten grants because they're considered as high-risk cities, and Broward County as well. So really, especially if you're in the South, you're very likely to have gotten this grant. So Georgia, Mississippi, areas in the South that have really high HIV and STD prevalence, what they call as HIV hotspots, now have this grant. And this is a 10-year grant. Like I said, it's going to go towards various different aspects of our work. So one, it's going to help us hire more staff. Two, it's going to help us do more educational trainings for our staff so they can be more culturally competent and sensitive when it comes to serving, oppressed communities, especially the LGBTQ community, the Latino community, African American community, the Asian community, etc. It's also going to expand access to PrEP as well as HIV testing hours, so that we can make sure that we're really reaching out and going to the communities that need it the most, right? And the application deadline for that is unfortunately over. So whatever organizations have applied have already gotten it. There was one type of grant that was specifically for CBOs, community-based organizations, to carry out HIV testing. And then there was another set of grants specifically for government entities, like DOH, parts of Health and Human Services. So we got for about $300,000 to testing and PrEP education and accessibility. So we have been starting the grant as of January, so we're about a month into the grant. So I really see the difference. We're really able to have more staff now and really dedicate more resources to reach the community, unlike that we've ever been able to do before.
I noticed that there are at least 3 participants who are not on video. I just want to acknowledge that I know that you're there and to invite you to ask any questions at this moment if you've got one. No? Okay.
All right. No, no worries. So I can go into the next part of what I was going to talk about today. So I wanted to go a little bit back. Thank you. I wanted to go a little bit back to HIV. So we often hear, HIV and AIDS being mixed as the same, but HIV and AIDS are in fact not. So HIV is the early acute stage infection. That's when you're initially affected. At that point, the T cells do good news. The earlier that you get tested and the earlier that you take medication. So for people who are HIV positive, it's called as antiretroviral therapy. So there's a variety of medications now. Unlike before where there was only one medication, there's a variety of different medications that your doctors can look into based on your blood type and your genetics and appropriately prescribe you those medications. And some people might have to take a combination of different antiretrovirals. But the earlier that you take the medication in the HIV infection stage, the greater chance that you have of reducing the number of HIV cells in your body. So we as public healthcare professionals, we want to ensure that people are not only going to their initial HIV appointment and getting the medication, but that they're retained in care by going to the doctor every 3 to 6 months and maintaining that for a long period of time. Because when you're able to take that medication for a long period of time, you can become what we call as undetectable. So an undetectable means somebody who now has a microscopic amount of HIV infection cells that it cannot be detected by a microscope. So we have a campaign called as U equals U. So undetectable equals untransmittable. So if you are initially HIV positive and you take antiretroviral therapies for the rest of your life, you do have to take it for the rest of your life to be able to keep reducing the number of HIV infection cells in your body, then you can get to that point of being untransmittable, where you no longer have to worry about infecting others during sexual intercourse, right? But AIDS, which is autoimmune deficiency syndrome, is the last and final stage of HIV. So these are individuals that have been HIV positive for, let's say, 20, 30, 40 years. And at this point, the number of T cells is 200 or less. So basically at that point, your immune system is non-existent. Like I said earlier with the example of touching this, right? When I was HIV negative, I don't have to worry about that. But when I'm an AIDS patient and I now have less than 200 immune system cells, something as simple as me touching my wall and coming into contact with a bacterial infection could possibly lead to something as serious as death, because my immune system at that point is unable to protect me from even the smallest of infections, which is why we see that most AIDS patients tend to only live about 3 to 4 years. So we really, go out in the community and encourage people, it's up to you to really take charge of your sexual health, to be able to get tested as early as possible and to go every 3 months and to be able to continue to take that medication to become undetectable means that you can still live a long and healthy life. So we've heard, of people living up to 100 years, up to 90 years, living completely healthy because they took medication for a long time. For example, my colleague, who works mostly with gay and bisexual men, was HIV positive at 20 years old. But now in his 60s, he's been taking HIV medications for 40 years straight, consistently following what his medical professionals have told him to do. So at this point, he's undetectable. He's living a long and healthy life. He's definitely more fit than any of us, despite the fact that he's HIV positive and older than all of us in the office. So, don't give up, just because you're initially HIV positive, it's not the end of the world. But the longer that you wait and the longer that you procrastinate and put off testing and put off getting the treatment, the harder it's going to be to ensure that you do get to the uninfectable stage. So
I see you have a question. Irma, I see you have a question.
Question. I do have a question. Avani,
Okay.
thank you so much. This is just amazing, this webinar. How can we reach out then to the most vulnerable, the sex workers? How can we communicate to them to trust us? And how can they have access to the medication? And where would they keep the medication? Because that's another thing. Does it need refrigeration? Is it a shelf life? These are issues because they're the ones that need the most protection.
Right. Yeah. So I would start by saying that, we need to outreach workers be a part of the community. But as medical professionals, I think we should do a better job of recruiting people, transgender community, minority communities, low end that are a part of communities. Some of the most effective strategies, for example, Transsocial. They actually go out there when the girls are doing their stroll and they do condom distribution in Miami Beach and Little Havana. Another idea that I've said as providers, having late night testing, because a lot of sex workers work irregular hours. Maybe having like a conspicuous bag in terms of like the condoms and the PrEP medication. In terms of refrigeration, I don't think that that's a big deal as long as like you have it that it needs to be at. I'm not sure about the shelf life. A bit beyond my qualification on exactly the medication shelf life. So that may be a more appropriate thing to ask, say, a primary physician. Because as a caveat, my job is to educate people about the benefits and side effects of PrEP, how you qualify, how to get there. But at the end of the day, the only person that knows for you whether PrEP is right for your individual experience is your primary physician. So you always want to defer to your primary physician to know about whether you specifically are the good candidate for PrEP. Another thing that I think that providers can do, especially like in their clinical settings, let their patients know that it's a diverse clientele. Put a statement about gender identity and sexual orientation. Have gender neutral bathrooms. Have LGBTQ magazines and newspapers in the waiting area. Ask people for their pronouns. Things like that. Something is basic customer service. Approaching your clients with a smile. Treating them with respect and equality like a human being. Not asking them intrusive questions about their surgical history, about, like you used to be a guy, who are you having sex with? And just like showing that general sense of competence really goes a long way. So one of the things that I have been doing in conjunction with my sexual minority coordinator is we've been doing LGBTQ competency trainings for providers around the county. So we've been showcasing, what's good customer service and what's bad customer service, right? So I can share an example that I had as a patient. I went to this clinic one time, and I was going there as a transgender person trying to start hormones, and the doctor just didn't know anything about hormone replacement therapy. Oftentimes trans patients have to explain to our medical providers what it means to be transgender, what it means to be on hormone replacement therapy, how much of the medication that we need, how to appropriately refer to us and gender us. So I was asked by a doctor, so how far along are you on the transition? Have you had any surgeries? Are you having sex with boys or girls? What was it like to used to be a man? All these unnecessary and intrusive questions really does leave a bad feeling in the community. And it's why people don't trust us, right? So as a provider, the first thing you can do is ask people for their pronouns. Don't ask any question about their surgeries unless it's relevant to the care that you are providing. Take some time, to learn about different transgender health topics. Know what it means to be on estrogen versus testosterone. Know what the effects of progesterone is for trans women, especially in their breast development. Know the risks of breast cancer and blood clots for hormones. Knowing to recommend to trans women to be able to take their breast cancer examinations after a year of hormones. These are all small things that if you take the time to learn, you'll really get trust within the community. And I know this because I've done focus groups across this community. I've spoken to hundreds of trans women, men, and non-binary individuals. And this is what they've told me. They've also shared their concerns when it comes to the PrEP campaign. They don't feel that the people that are in the advertisements or in the radio ads are representative of the transgender community, that it's often male dominant. Men are 14 times more likely to be PrEP users, despite the fact that women of color and trans are in equal need of PrEP. And we also see that, 54% of the HIV infections are happening down here, down south, but only 30% of the population in the United States in the South are PrEP users. Whereas in the North, which only has about 1/4 of the HIV infections, they're the highest number of PrEP users. So when we look at the statistics, we see that more people are taking PrEP, definitely. Compared to 2012, we're definitely seeing an increase, but we're not seeing an increase in the right areas. We're not seeing an increase amongst women. We're not seeing any increase amongst sexual minorities. And we're not seeing it in the transgender community, in the African-American community, and in the Latino community. So it's really making sure that we have a diverse workforce, that we have a good non-discrimination statement, and that we really go and learn about different transgender resources. One of the best ones that I can say is the University of California, San Francisco. They have a set of recommendations for how to treat transgender people and to offer care that is written and done entirely by the transgender community. And now another major health organization that's internationally recognized is called the World Psychological Association of Transgender Health. So these individuals, they meet every 2 years, and they set up what they call as standards of care for the transgender community, in terms of making sure that, they get a doctor's note, that you're offering care that is done through informed consent, that you're not, gatekeeping trans people from getting hormones. So I wanted to explain a little bit of a difference in terms of gatekeeping versus informed consent. Okay.
Could I pause you just a second, Vinny? Can I pause you for just a second?
Yeah, no
we are losing our ability to see you as it gets darker here in Florida. So if you could turn on a light, we'd be able to see you.
Okay, 1 second.
Thank you. And again, I just want to say welcome to DeMarcus and our other participants that I know are here. Good, welcome this evening. We can see you again, yay!
Right. Okay, so I just wanted to go back and talk a little bit more about informed consent versus gatekeeping. So traditionally, the providers that have treated transgender people have been practicing this methodology of gatekeeping, where they require the trans person to go through a certain number of mental health sessions. They keep leading them on and making them pay tons and tons of money to get letters from their primary physician, and they make them, have to, dress as their preferred gender in real life for 6 months before they can start hormones. So these were a lot of the obstacles that, trans people were facing. Back before the Affordable Care Act, most insurance companies did not cover transgender care. A lot of them still consider it as cosmetic and not medically necessary. So it was hard for them to get covered by insurance. So they had to end up paying a lot of costs just to get a medical letter to go through this process to even start. But a more recent and advanced procedure for gender affirming care is called as informed consent. So this is allowing the transgender patient to start their transition when they want to be able to get them to where they need to be as quickly as they can. So part of that is the depathologization of gender identity. So for years, until 2012, being transgender was considered as a mental disorder. Why they required you to go to a mental health counselor and to get the certificate, because it was under the assumption that transgender people are mentally ill and have something wrong with them. So therefore, they need to be checked by a mental health counselor. But it was removed as a mental health condition in 2012. And most practices no longer require you to go through a certain amount of mental health sessions in order to get the hormones. So the informed consent approach, basically you sit the patient, you know about the effects of hormones, what effects are reversible and irreversible, what side effects could happen to you, and also like doing blood work and letting them know that, they're physically healthy to be able to start the hormones, and then letting them start when they want. We now have more insurance companies because of the Affordable Care Act and the non-discrimination policies that are now covering it as medically necessary. Medicare, Medicaid, any kind of government health insurance program now directly covers trans care. And, there's a lot of resources here in the community where you can get letters for free from your primary without having to go through a long process. Trans example has been working with the Greater Legal Services of Miami for people that are individual earners making less than $30,000 a year to be able to get their gender marker change, driver's license, on their social security, on their passport, on their birth certificate, without incurring any of the costs that they had to before. So we're definitely an expansion and free and accessible care when it comes to gender affirming services. Resource, for example, is a federally qualified health center. It has various locations both in Broward County and in Miami. And they give to people that have insurance so that they can offset the cost and get their hormones and get their treatment entirely for free. And they have a sliding scale fee. So the more money you make, the more you have in terms of your copay. But I make sure that everybody is served, right? So, and one of their main barriers that we see is access to transportation. So, on our community partners, we now have programs where, people like AHF, other providers, they give Uber and Lyft rides to their patients so that they actually go to their appointment for their HIV follow-ups and for their testing and to be able to pick up their medication. There are organizations that offer assistance with housing for LGBTQ youth. Especially the homeless population, 54% in Miami-Dade County accounts for LGBTQ youth. So there are now more resources to reach out to their communities to ensure that these economic barriers and factors that were previously preventing people from getting HIV testing and medication is no longer an issue, right? So we also see that in the trans community, the viral suppression rate, the ability to become undetectable, is lower than the average population. So in Miami-Dade County, only about 54% of people who are initially HIV positive are virally suppressed and get to that undetectable stage. For the trans community, it's about 49%. And that's according to the clients who use the Ryan White program. So the Ryan White program, it's a federal program for people who are HIV positive and make under a certain income. They're able to get assistance with housing, with their drugs, with transportation, and different aspects of HIV care. So in the data that they collected from trans men and trans women, they're still seeing that, we have a lower viral suppression rate. So it's not just about, bringing the client into the hospital and getting them in their first appointment. You have to ensure that they're retained in care. So, they're really making sure that they're doing more reminders for clients. certain organizations are now developing apps where clients can see their appointments. They get reminders from time to time to ensure that they don't miss their appointment. At DOH, while we don't have the same abilities as our community providers to provide transportation, we do have individuals called as disease intervention specialists. So these are our individuals that go directly to the patients who are HIV positive and follow up with them every 3 months to make sure that they're on medication. They're also legally required to notify people that they're HIV positive and to deliver mail to their house and to make sure that, they're informing their partner. We have a partner notification system and things like that. We do have, county vehicles, although limited, where, drive our patients directly to the clinics now to make sure they're getting tested and that they're getting their medication, right? So with talking about HIV, we also have a whole nother ballgame when it comes to sexual diseases, and that's sexually transmitted diseases. So while HIV prevalence, is the highest in Miami-Dade County, we are number 1 in that. Nationally, STDs are at an all-time high now for young women and young men 15 to 24. This gonorrhea and chlamydia, we're seeing a huge, and that's because a lot of people have perceptions of what it takes to become infected with an STD because they don't understand the difference between STDs and HIV. So for example, okay, let's say HIV, you can't get it through casual contact. So if I kiss somebody, if I hug somebody, if I cuddle somebody, I won't get HIV. But the caveat is that somebody who has an STD, gonorrhea, or lip, to contact with that, I can get infected. If I finger someone and there's an STD on their vagina and I wash my hands afterwards, let's say I rub my eye, I rub my face, then I can get an STD on my face, right? And STD is similar to HIV, is for the most part curable with the caveat of these, which does have a medication to mitigate the effects of herpes, but that most STDs are if you take the medication at the earlier stage rather than later stage. So most people with STDs, they can go years without having any visible signs that they have the STD, which is why it's really important that when you are sexually active, that you do continue to get tested. This is the only way to know. A lot of the pictures that we see about gonorrhea, chlamydia, and syphilis, we see the war, we see, how the tongue looks weird, and all this different stuff. Those had STDs for 20, 30, 40 years. So those are individuals who are at a really late stage that have not taken the medication that end up in that way. Both STDs look quite normal. They look just like us. You wouldn't be able to tell that they're STD positive unless tested. So another way to prevent STDs is dental dams. Dental dams for oral sex. So a lot of people, they see oral sex as not sex, low risk, and overall in comparison, oral sex is the least risk way to transmit an HIV or STD compared to anal sex, which has the highest risk, which is see that bisexual men have the highest rates of HIV. They account for over 75% of HIV infections here in Miami-Dade County. But dental dams, they're basically like this plastic wrap. You take your pointer finger and your thumb and you just kind of extend it on both sides and you place it over the body part that you're having oral sex on. So if you're giving, a blowjob on a penis or on a vagina, then that's something you can cover. There's flavors as well that you can use for oral sex. You also have finger condoms for fingering so that you can protect yourself. So there's many types of condoms and new ways that people have never before heard about. Like when I go into my educational sessions, nobody knows how to use a dental dam. Nobody knows how to use a finger condom. And surprisingly, a lot of women that don't know about female condoms. Female condoms, they can be inserted into your vagina and you can have it 6 to 8 hours before going into sexual contact. So you can wear it with you before you go to the party, have it on all night, and have it ready right when you're about to have sexual contact. So you already have it on. It makes it easier because you don't even have to negotiate condom use with your partner. Another, difficult aspect of HIV transmission, a lot of people aren't able to get past that social pressure when a partner says, oh, it'll feel better if we have, condomless sex. We know each other. That I'm HIV negative. Why do we have to use a condom? Those negotiation skills, which we do teach as health educators and try to get people to learn, they can be a lot easier when you're already wearing the condom, when you're already taking that step. And another thing is that female condoms offer protection against human papillomavirus, HPV, whereas a male condom does not. So the female condom is actually more effective at preventing HIV than the male condom. And I think, we really need to reach out more to women. We need to do more PrEP education sessions for women of color, talking about female condom, how to use the dental dam, how to use finger condoms, and really teach them about good negotiation skills when it comes to talking with their partner. How to be able to tell your partner, I love you, I trust you, I know that, but, I really would like it if we could wear a condom. It would really make me feel more safe and comfortable. Maybe we can go together and get HIV tested so that, it doesn't feel awkward for them, like you're accusing them of having HIV, but it just really those precautions, like getting tested together before you have sex, making sure you have a conversation about condom use, or, if you had any kind of previous STD or HIV, letting your partner know about that. Especially in Florida, you're actually legally required to let your partner know that you have an STD or that you have HIV infection before obtaining consent for sex. So in the state of Florida, if a partner finds out that you infected them with HIV, you can actually face a felony or a misdemeanor, depending on whether it's an STD or an HIV, and face actual jail time for not informing your partner. So it really does start with, just having those conversations and just, being real with your partner and letting them know about why it's important to use condom and how it's better for both of you. So I think, we really have to help people with negotiations, right? And we also need to do more about PrEP outreach and education for women. We're 14 times less likely to use PrEP despite having the same amount of need. And that's because most of the PrEP education materials are all centered around men. A lot of think that, PrEP is only for gay men. It's a gay men medication. And it really discourages a lot of people. So we've really been making more of an effort to do educational sessions this year in women's health clinics and substance abuse clinics that are women only, in different areas, especially going out to more lesbian events led by women, doing outreach there, educating them about condoms, educating them about, our plan. So just to get back to our plan, other than ending the HIV epidemic, the federal initiative that was recently started, Miami-Dade has something called as the Getting. So in 2014, Mayor Carl Jimenez, he convened this task force. So it's a variety of stakeholders. It's professors from FIU, from all different types of universities, primary physicians, health educators, members of the community that are directly affected have come together to getting to zero campaign, which means zero infections, zero people that are HIV positive that don't know about their status, and zero people that are HIV positive that don't end up becoming undetectable. So we want everybody that's positive to be retained in care and to become undetectable. We want to prevent all HIV infections before it occurs, and we want to ensure that we test people as early as possible, sorry, not as early as positive, right? So this initiative has a variety of different aspects to it. We do educational sessions in the community. We have billboards and flyers across the county. We have different community meetings just to ensure that we're really reaching our target population, especially doing more outreach and condom distribution in bars. Latino Salute is pretty good at that, reaching out to Hispanic men, doing condom negotiation classes, talking about partner notification, making sure that we have the mobile units available, which offers free HIV STD testing. So, if you go to testmiami.org, which is our website, people can find out about when we're testing and where we're testing and come based on whatever their closest location, whatever is the most convenient time, and get tested all STDs plus HIV for free. Unlike any other private practice where they would charge you about $160 to get the same test, if you do it through us, you can get it for free. And we let you know about your HIV test result right then and there. And then for STDs, it takes about a week. You have to process it in the lab, and then we'll let you know. And then we immediately try to get people into care within 48 to 72 hours. We've had people are HIV positive, they find out on that day, and then we get them into a session with their primary physician and get them the medication that night, right? So we're also taking it on ourselves to be able to get people their medication faster as well, so that they're not waiting for that infection to multiply and replicate in their body before it's too late for us to be able to assist them. Okay? So with that, I'll take more questions, and then I'll go through one last section before we end for the day.
So let me ask you, Vani, I know we used to do Western blot and ELISA for our testing. Are
Okay.
those now passe? Are those we don't use those tests anymore?
We actually now have much different technology where it does no longer takes 20 minutes for the HIV test to come up. It's called the instant test. So we now have instant tests rather than the finger prick, where we can instantly tell if somebody is HIV positive rather than waiting for the blood through the finger prick for 20 minutes. So we are now requiring that all HIV counselors and testers in the county take the HIV instant test that is provided through us. If you go to testmiami.org, you can find out about that as well. Also, if you want to become an HIV counselor, we have something called as a 500-501 course. So anybody, regardless of their educational qualifications, can come with us, take this online course. Then they would come to us and do a 2-day educational session at DOH, where we would present them about different topics, let them know about different situations that they would come up with, and they can be certified as HIV counselors and testers here in Miami-Dade County. Now, it doesn't guarantee you a job placement, but it's a great certificate to have on your resume to be able to get that job when you are interviewing for the health department, for Jackson Hospital, for So me, for example, I was a volunteer with Survivors Pathway before I came to the health department. So I was, doing the intersections between domestic violence, immigration, and HIV positivity. So I was able to have the opportunity to take the 500-501 course. And I was able to, meet with healthcare professionals who are working with the health department. And that eventually helped me get the recommendation and the recognition that I needed to get the job as transgender services coordinator 3 months after I went to that course. So it's also really good to be able to, go out and meet health educators in your community to really put yourself out there, build networks. That's a very important way to get employment, especially in health education, is knowing people. So, don't be afraid to go out there, do internships, go to these free HIV STD trainings, learn as much as you can, especially if you're in a community that is disproportionately misrepresented in HIV STD work. Latino women, African-American women, trans men, non-binary individuals, Latino, gay, bisexual men. I really do encourage you all to get involved in this field and to directly work to change it, because that's what inspired me to get into public health. I had a teacher who was non-binary in my undergrad, who I took medical sociology with. And, I told her, I really feel that transgender health field is underdeveloped, that there's not a lot of research. And, we're having to do a lot of work in educating these doctors, but that there's not enough transgender health professionals who are directly going out there and changing the system. So that's why, my professor encouraged me to go into public health, because she said as a transgender woman, I could have an important voice and directly be there to change it rather than expecting others who are not a part of the community to make those changes, to have members of this community directly go involved in getting into these positions and to get involved.
Excellent. Excellent. Yes, because pretty much everybody on the call are marriage and family therapists. And so this is information that we might not actually go do the frontline work that you're doing, Vani, but certainly we need to know these resources to let people know, and wherever you are in the state listening to this, to go to your Department of Health, find out who's got the grants, so that you can tell your clients where to go for the Insta-test and all of those kinds of things. The Insta-test, is it a cheek swab? You said it's not blood. What is the Insta-test?
Oh no, it's still prick. You're still getting
okay,
pricked. It's just that the result comes faster than the finger prick before.
That's amazing.
But
I started in HIV in 1995, so that was in the old days of ELISA and Western blot and waiting 2 weeks to get the results and all that kind of stuff. So it has changed a lot.
I wanted to add one thing. Sorry, yes. one thing. So you said cheek swab. So there is something called as the take-home testing kits that people at Jackson Hospital, us as well, that we're trying to hand to people. This is more convenient for them. They can do the test at home. That does involve the cheek swab. You have to not eat anything for 30 minutes before the test. You have to rub it around both of your cheeks for just a little bit, just 2 or 3 touches. And then you put it inside this capsule that you're given. And you just let it sit there for about 30 minutes. And there'll be a little pH color. If that pH turns yellow, then you're HIV positive. If you don't see it turn yellow, then you're HIV negative. And you can find out directly your result at home through the cheek swab.
Like a
So we're
pregnancy
really trying to
test.
expand access to that as well. That would be really helpful for sex workers, I know, who can't directly go to the clinic or don't want others in the community to know that they're getting tested for HIV. That is actually a good resource.
Is that purchasable at Walmart and CVS and things like that?
I don't believe so, but
Okay.
definitely Jackson, any kind of health clinic, HIV clinic, DOH, you can get the take-home
Would have
testing
those.
kits.
Okay, great.
Yes.
Great. Okay. So the person's that's on the phone, or DeMarcus, do you have any questions?
Not at the moment. I loved all the information that was shared. This is something I never really knew a lot about, being a new graduate of intermarriage and family therapy, a new professional. So I really enjoyed this presentation. I hate that I didn't catch it at the beginning, but when I caught on, I was able to kind of catch up.
Will you be able to watch it from the beginning when we post it on our YouTube channel?
Awesome. Will this also be available like written in terms of the resources and things like that, or?
We can certainly get all those, and we'll put them on our website.
That'd be awesome.
Yeah, so what I will do is I will email links tomorrow when I get back into the office to Dr. Irma Barron and to you all. I will put Testberg. I'll put the different community organizations that are available. I don't know where you guys live, so I mean, that's another thing. If you guys can maybe give Irma your locations, I can try to find out resources in your area as well.
Yeah, even if you just gave us for the 5 biggest cities, that would be wonderful, and we could at least get people started that way. Even if, say, DeMarcus were in Tallahassee or near Tallahassee, the Tallahassee people would be able to tell them where else in the Panhandle and that sort of thing. So,
right.
Yeah, that'd be great.
So I also want to let you all know, as therapists, you actually do play a big role in HIV prevention. So, for example, our data shows that people who attend mental health sessions or don't go to their counselor consistently are actually more likely to be HIV positive. So the more that people go to counseling and, go to their counselors and get retained in therapy, the less likely that they are to become HIV positive, because it boosts self-esteem. It helps them coach through substance abuse. Substance abuse is one of the highest risk factors. People that chew tobacco, smoke, drink alcohol, inject drugs are way more likely to be HIV positive. So as a therapist and as a counselor, you really can play a big role in helping people boost their self-esteem and getting them motivated to go to their appointments and letting them know the importance of getting tested, not engaging in any kind of risky behavior during substance abuse. Coaching them through those issues is a big deal. So I think, expanding access to mental health, making sure that therapy is available for everybody can play a big role. In fact, one of the most important roles in reducing HIV infection. So for example, I worked at Survivors Pathway. We did free therapy and counseling sessions to HIV positive individuals, domestic violence victims, people who are most in need and also most likely to be positive. That's played a big role in getting people out to their treatments, making sure that they go to their appointments, making sure that they're staying on their medication. We also have support groups for people who are HIV positive, people in the trans community, people who are, victims of domestic violence, because having that sense of community, that camaraderie, talking to other people who are going through similar issues as you are, makes them more likely to feel that they're not alone and that what's going on with them is not something that's unusual, that it's totally normal. You can still get treatment and you still have hope. So you guys are actually playing an important job, and we need more therapists and counselors for this work.
I'm getting a note from Meredith saying this is great information, and that she's in Orlando, where there are very high rates, especially with male sex partners of males, and the power relationship really does make a difference, she says. So yeah, so Orlando is another, one of those major cities. I'm sure they got one of those grants. Somebody in the Orlando area has one of those grants. So very good. Stacy, do you, oh, Stacy, okay. And Irma, any last questions before we thank Vani for the time today?
I'm going to make sure that this information gets added to our human sexuality courses. So Avani, any information that you can send me that I can then reach out to the professor that teaches that class would be beneficial. Thank you again. Thank you so much. I really
Right. And we look forward to those resources, and I'm sure several of us have taken notes, and we can put that together on the website so that when people view this, they have those additional resources as well. So
Sounds good.
thank you so much, Vani, particularly knowing that you had a cold today. So thank you for being so energetic. I would never have guessed that you had a cold. So thank you so much for this evening.
thank you.
I appreciate that. I really appreciate you all. Thank you for inviting me. As a closing message, I do want to tell you all, when you go back to your workplaces, like evaluate what you guys can do better, what you're doing good, what you can do differently. Look at, the staff that you're hiring, how educated the staff are. Do you have nation policies? What resources can you give? How can you improve your syllabus to include these topics? Because it's only through self-reflection and by working every day and being honest with ourselves and learning that this is a process where we grow together rather than, something that we automatically need to do. This is, a growing and learning experience. So really, take that time to see where your organizations are at and, have an honest conversation with your coworkers and your family.
Thank you so much.
Thank you.
Thank you all.